My name is Tola Rosamo, and on behalf of the Harvard Medical School planning team, I'd like to welcome you to the Veritas Forum at HMS. And welcome to those in our overflow. We are very glad you are here. The Veritas Forum at HMS is sponsored by the Center for Bioethics, the Initiative on Health, Religion, and Spirituality, and the Program on Integrative Knowledge and Human Flourishing at Harvard University. Tonight's event is not a debate. We're not here to see people win or lose or score points off of each other. Veritas is Latin for truth, so we're here tonight for a real discussion connecting truth to our hardest questions and deepest beliefs. We have asked our presenters to share personally, ask honest questions of each other, and model a conversation that all of us can continue this evening and beyond. Our hope is that everyone in this room would be challenged. The Veritas planning team aims to create events that are relevant, thought-provoking, and engaging to people of all backgrounds and beliefs, and we need your help with that. Please pick up your Veritas 60-second survey card and a pencil we've provided and take 15 seconds now to fill out the top half of the front side. I'm going to do it too, and I'm going to give you 15 seconds. Okay. We'll only use your email address to send you a link on tonight's feedback site where you can share your thoughts on tonight's forum. We really want your feedback, so please do sign up for that. And we will not email you about anything else unless you check one of the boxes at the bottom of the card or you win the iPad and we're telling you that you're a winner. After the conversation, please fill out the remaining sections of your survey card, both the front side and the back side. At the end of the forum, please bring your card with you as you exit and leave it in one of the boxes provided. We are thrilled to have tonight's conversation between Professor Daniel Sulmasy and Professor Lachlan Forrow, moderated by Dr. Alexandra Cist. Could we please welcome the speakers to the front with a round of applause? Dr. Sulmasy is a senior research scholar at the Kennedy Institute of Ethics and holds a joint appointment at the Pellegrino Center for Clinical Bioethics. He's the inaugural Andre Helgers Professor of Biomedical Ethics with co-appointments in the departments of philosophy and medicine at Georgetown. His research interests encompass both theoretical and empirical investigations of the ethics of end-of-life decision-making, ethics education, and the spirituality in medicine. He also continues to practice medicine part-time. Dr. Sulmasy holds a PhD from Georgetown University and an MD from Cornell University. He completed his residency, chief residency, and postdoctoral fellowship in the general internal medicine at Johns Hopkins Hospital. He's previously held faculty positions at Georgetown University and New York Medical College. He has also served on numerous governmental advisory committees and was appointed to the Presidential Commission for the Study of Bioethical Problems by President Obama in April 2010. Dr. Forrow is an associate professor of medicine at Harvard Medical School, director of ethics and programs, and a longtime palliative care physician at Beth Israel Deaconess Medical Center. He received his MD from Harvard Medical School and completed his residency training in primary care internal medicine at Rhode Island Hospital and Brown University. Dr. Forrow was a faculty fellow in ethics from 1988 to 89 and became the faculty associate of the Ethics Center at the end of that year. In 2007, Dr. Forrow was awarded the Lifetime Achievement Award for Community Service from Harvard Medical School. Dr. Cist is a physician with a background of pulmonary and critical care and ethics at MGH. She received her MD from Yale and came to Harvard 25 years ago for clinical and ethics training. She focuses on clinical ethics, especially in the end-of-life care and intensive care units, and trains new members of ethics committees in ethics consultation at MGH and other partners hospitals. She teaches an ethics curriculum at the Harvard Medical School and serves on several ethics committees. We are privileged to have these three people here joining us for tonight's Veritas Forum. I hope to see all of you at future gatherings exploring the facets of these issues, and I encourage you not to let this conversation end here. Thank you again all very much for coming tonight, and please join me in giving a warm welcome to our speakers. So before we hear from Dr. Cist, I have one quick announcement. It's not to tell you to turn off your cell phones, even though silence is golden, but to actually encourage you to text during the forum. Specifically, we encourage you to text your questions to our presenters throughout the evening to the number behind me, or actually more to the website behind me. And during the Q&A, we'll choose the most popular questions, and the moderator will present them to our professors. And you can choose to remain anonymous, but if you would like, you can identify yourself by what you do. So for example, medical student or palliative care nurse. And that's it. Let's start.
Okay, thank you, Tolu. It is actually a privilege and delight to be here because I was in your seat 25 years ago when the first Veritas Forum occurred, was hosted over at the Harvard Law School, and there have been many over the years. So it's a delight to be on this side, seeing all the faces. I have admired these two particular gentlemen for a number of years, known them and have admired them. And I wish I had them just to myself in front of a crackling fire over wine and cheese to probe their hearts and minds over this and many other topics. I suppose that there will be a little bit of heat generated, so we can still pretend that we have the fireside chat. Our program title is Physician-Assisted Suicide, or Physician Aid in Dying, a discussion on religion and ethics at the end of life. And the impressive turnout tonight, I think, indicates that I do not need to emphasize the importance of this topic. And yet, the impressive turnout tonight might also indicate that there remains some confusion or uncertainty over where one may stand on this issue, or where one feels one ought to stand on this issue. So thus, the program. In our title, we've included two different phrases to describe the practice. And the local community ethics committee that is made up of total non-clinicians came up with another phrase. They called it choosing medically induced death. Here in Massachusetts, a referendum on physician-assisted suicide, physician aid in dying, was defeated in 2012. But currently there is an act before the Massachusetts State and House and Senate in the Committee on Public Health called an act related to end-of-life options. So now we've heard 4 different ways to describe an act of prescribing somebody a lethal substance that they might take to end their lives when they have a terminal illness. This is very much in the public. It's also very much in the private spheres. So we are opening this forum tonight to bring it into this sphere and welcome the 2 speakers. The format tonight is that Dr. Forrow will begin and have several minutes to present his presentation, and then Dr. Sulmasy will give his presentation. Dr. Forrow will then have an opportunity to respond to Dr. Sulmasy, and Dr. Sulmasy to Dr. Forrow, and then we'll begin with some moderated questions, and then the questions that you text in. Dr. Forrow.
All right. Can you hear me? Does the mic now work? If I can get the slides. I don't know whether someone needs to help me. No? Anybody know how the slides come up? Let's try this. Unless somebody can show me where the slides are, I'll just talk. They were set up, but all we have is the master slide.
Did you put it on the desktop?
Yeah, yeah, and it was.
Okay, maybe let's close this down. Or maybe minimize it. Right, cancel. Minimize. Yeah. Let's see if we can see it on the.
There we go.
Is that the beginning?
Yes, yeah, we're good. We're great. We're great. And does this work? Yes. All right. So thanks, and I will try to keep us on time anyway. A couple of preliminary remarks. I really am thrilled with the whole spirit of the framing of this by the Veritas Forum. This is not a debate, although I hope that you'll hear between me and Professor Sulmasy, Dan, someone I've admired for years, maybe even sometimes pointed disagreements about different things, but the goal is not to win or lose a debate. The goal is to try to catalyze all of us to think about this issue. When it was on the ballot in Massachusetts a number of years ago in 2012, as Dr. Cist mentioned, the thing that was actually most worrisome to me, and the first thing I'd written a series of blogs for the Boston Globe, first one I wrote about it was basically a pox on both your houses. Because as far as I could tell, both sides, those favoring legalization and those opposing, were trying to scare people, and frankly, things that both sides said I thought were lies. If this passes, insurance companies will start pressuring you to end your own life rather than give you medical care. Just like that was not going to happen in Massachusetts. If this doesn't pass, then all kinds of people with cancer are going to die in terrible pain, which just means their doctor's incompetent. Right? So it is very, very hard on this topic. These days, almost any topic in this country about which people have different views, to actually have a respectful, thoughtful discussion about how we move forward. Second, even if you say terms of win-lose about this, whatever happens in Massachusetts about legalization, we all have to live together in the Commonwealth of Massachusetts, and how are we going to live together given the fact that we have some disagreements? So the point of this forum, I hope, is not to convince you of A or B position, but to help you learn how to think about this issue, talk with each other, and show by example among yourselves and with other colleagues that it is possible to live in a wonderfully diverse and pluralistic society like this country that most of us love so much in a respectful way, which I think is one of the things that we most badly need, not just on this topic. I'm going to go over a number of things very quickly just to get us started. When I was talking to the organizers and was delighted that Professor Sulmasy was one of the speakers, as you'll hear, he has serious qualms about the legalization or the practice of physician-assisted suicide or medical aid in dying or death with dignity. And so I said, then I think you need somebody to really make the case for legalization, even though people who know me know I really have most often expressed qualms and hesitations. But I see my role, starting us off, to really explain why I think we need to take the arguments for legalization really seriously. Before I do that, I'm going to give you my KISS, keep it simple, stupid view of all of ethics in just a few sentences. One of my heroes, Dr. Albert Schweitzer, probably in the mid-20th century, the most revered doctor in the world. I'll skip biographical kinds of things, but he gave up an extraordinary career in Europe where he was one of the leading theologians, the leading Bach scholar, and gave all of that up to go to medical school to be a doctor in Africa. But in Africa, he continued to reflect on ethics and philosophy. And after 3 doctoral degrees, lots of books, other things, he concluded that all of ethics, as he studied traditions around the world, all of ethics was ultimately at its bedrock basis a question of, in German, he was German, Ehrfurcht vor dem Leben, but in English we translate that as reverence for all life. Now this phrase reverence doesn't really capture what the German phrase was. Ehrfurcht for life, reverence as we confront or on behalf of life, is a combination of awe about the miracle of life, the existence of life, awe, out of that respect for every life you see around you, and then when that life is vulnerable or in danger, a sense of responsibility for that. He summarized in one sentence that ethics alone consists in this, that I experience in myself as a thinking, caring human being the necessity of practicing the same reverence for life toward all will to live, toward all life as I do toward myself. And as he studied, he found different words for this in essentially every religious tradition in the world. He was raised as a Lutheran. He was actually an ordained Lutheran minister. He found it in Judaism. He found it in Buddhism. He found it in Islam. Different words, different language. He said what ethics is really about is our sense of the value, the sort of awe of things, and life is foremost. And if we really take that seriously, responsibility for that. And then he further believed that when we cultivate that human capacity to experience and express reverence for the life around us, when we act on that and actually make a difference in that, he actually also believed we find the deepest possible human fulfillment that we can have. So that's a long history of that in like 3 or 4 minutes, but I'm going to probably allude to that time to time as we think about how do we apply that to the question we're talking about now, end of life and physician-assisted suicide. It's easy when you take that sense of reverence for life and apply it to a cute baby. It's harder if you're a doctor in Africa and someone with leprosy, Hansen's disease, comes to you, you might recoil, but actually this person may need you even more than the cute baby because everybody wants to help the cute baby. And somebody near the end of life, this is the last chance that we have in their life to experience and express that. What he said in a sermon before he went to Africa about this, he said, something deep and sanctifying takes place when people who belong to each other share the thought that every day, each coming hour may separate them. 100 years ago, people did not like to talk about the fact that they're mortal. They pretended it wasn't true, like us today. In this awareness, he said, we always find that the initial anxiety about death gives way to another deeper question. Have we given each other everything we could? Have we been everything we might have been to one another? What a different world this would be if men and women dared to look deeply at each other, if they kept in mind the prospect of being torn from each other. Each would then become sacred to the other because of death. Thinking about death in this way produces true love for life. When we are familiar with death, we accept each week, each day as a gift. Only if we are able thus to accept life bit by bit does it become precious. So I'm going to allude from time to time, underneath all the intellectual kind of discussions, how are we thinking, and it's not just thinking, experiencing, confronting the fact that there are lives around us and our own, they're finite, we can make a difference, what does that mean? Years ago, I chaired a state expert panel on end-of-life care. This was at the time that we started just before Sarah Palin and death panel controversy broke out. People said that now this is the polarizing, impossible to touch topic, third rail of politics. People disagree so passionately about it. The most important finding when we released our report at the Boston Public Library, with everyone I could find who had worried about death panels, there with us agreeing, disability advocates, conservative right-to-life Catholics, Orthodox Jewish people agreeing. I said, the most important finding is that everybody we found in Massachusetts agrees on this topic, which is basically people should be taken care of the way they would want from among the full range of medically, legally available options. Second key finding was our healthcare system's not even trying to do that. People get caught up, and there's all kinds of data, whether you get a feeding tube or ventilator, whatever. The evidence that it's actually anchored in you as a person and human being and your values is convincing that it too rarely is. So there's lots and lots of work to do. There's been enormous effort over the last 20 years to try to improve end-of-life care. That is work by a colleague, Joan Tino, has done in surveying. We'll see, just picking the reddish-orange bars. Over the last 15 years, things may even have gotten worse. In 2000, 15% of this is family members after death reporting what happened with their loved one. Significant increase in problems in pain management, and decrease in the proportion of people who said care was excellent. This is a real serious problem. And this is probably the only issue in all of healthcare, actually in all of life, that every single one of us and everyone we care about has a stake in. Human mortality is 100%. And when it goes well, people are sad at losing a loved one, but they look back with some of the deepest, most meaningful memories of the love, the caring of that person in any part of life. And when it goes badly, as it too often does, it's not just bad for the patient, but family members are left scarred and angry almost forever. So it is high stakes. And I won't even go into the amount of money that you all know is spent on these bad outcomes. So this is a huge issue. More recently in Massachusetts, the Massachusetts Coalition for Serious Illness Care, trying to work on improvement, did a survey which was sobering but confirming other patterns. Usually when you ask people to rate healthcare, you have 80 or 90% satisfaction, approval kinds of things. I've never seen numbers as bad as this, where barely half of people said the care of their loved one had been excellent or very good, and fully 20% said fair or poor. When asked, this is a little bit more complicated, but if you look at the middle section, I don't have a pointer, race, and then education, whites and more educated people had better results, but if you were non-white or less education or lower childhood income, it was even worse. Asked whether your loved one's wishes were very much followed and honored, you would think, well, that's supposed to be the one thing that happens. Only half said very much, and 20% only some, 15% a little bit or not at all. This is a huge, we have enormous amounts of work to do. In Oregon, where for over 20 years, the question we're talking about tonight, it has been legal, the care of most of the people in Oregon is better near the end of life, even though only 1 out of 300, about 3 out of 1,000 people choose this option. 99.6 or 99.7% of people in Oregon instead die at home with hospice without this choice. My main concern about this entire topic, specifically physician-assisted suicide, is we're spending all kinds of time arguing, talking about differences that even in Oregon, only 3 out of 1,000 people actually care about or exercise. The fundamental question is, how do we actually make sure that everybody is cared for the way they would want? Now, for tonight's topic, in the last few minutes I have, my father was a lawyer, passed away a number of years ago, was cared for the way he would have wanted, not thanks to me, the doctor, but thanks to my older sister insisting that we have conversations with mom and dad. And when just 1 month later he had an unexpected cardiac arrest, we knew what he would have wanted, not thanks to me, right? Thanks to a family member, said we have to talk about this. Right? But he said the most important thing as a lawyer is to know what the right question is. The question, I think, for us tonight in the main topic is not, do you think that this is morally wrong or not? Although I'm eager to talk and have us grapple and think about that. But at a policy question, it's given that the majority of Americans in every survey want and believe they should have at least the choice of this, given that many superb physicians believe that for some of their patients, it is the best, most caring way to care for them, given that decades of experience in Oregon has revealed very little evidence of any abuse, some would say zero, why should in Massachusetts or anywhere else, a fully informed patient who has access to hospice, has access to palliative care, anything that they would want, and their skilled, competent doctor be forbidden by law to even have this choice? Why should that be illegal, is the question. I think the arguments for it being legal are in some ways as simple as one of the most influential plays turned into a movie with Richard Dreyfuss a long time ago called Whose Life Is It Anyway?, which was about someone with a severe neurologic illness and the doctors were making all the decisions. He said, like, whose life is this? It's my life. I should get to decide. Quickly, the arguments for legalization boil into a number of categories. Patient autonomy. It's my life, it's my death, I ought to be able to decide. Who are you to say I can't do things the way I want? Patients' welfare and beneficence, the people argue that other alternatives involve at least the possibility of suffering, often frequent suffering, and so in fact this is the most compassionate thing. Physician autonomy is not often as mentioned as patient autonomy, but increasingly there are doctors who believe this is what my conscience and professional judgment means I owe my patient. Why should the law forbid me to practice the best possible medicine? Fourth argument is it happens anyway. We know it happens anyway. It's just hidden. And then we can't even know whether it's done with the proper safeguards, making sure the patient understood the options. Let's bring it out into the open. That'll be better for patients, families, and doctors. When it's been hidden, Dr. Tim Quill and others have written about cases where what happens often is families terrified somebody's going to go to jail. The patient's terrified family's going to go to jail, so the patient doesn't tell family, takes the medicine alone, dies alone. Why is that better than at least having it out in the open? Experience from Oregon, some people say when it's legal, people who are saying, oh, this is terrible, it should never happen, mobilize much more effectively to make the other options better. Safe, legal, and rare, the language often used for abortion, is something that can be a battle that's fought if it's legal. I've even suggested to leaders of the Archdiocese and others, if you really want to approach this issue in the future in Massachusetts, what I would love for you to do, if it becomes legal, is construct in inner city Boston. There is no hospice in Boston itself. The wealthiest suburbs have inpatient hospices. Construct one. It could be the Ted Kennedy Memorial Interfaith Hospice House. And tell anyone in Massachusetts, if you're tempted by physician-assisted suicide, come to us and we'll take good care of you. You can fight a lot of the issues without relying on the law. And Oregon's proven concerns are groundless. I'm going to end with just two quick stories. Marcia Angel, who if she were around, might have been here to present the case for legalization. If you're interested, you can Google Marcia Angel, New England Journal, or New York Review of Books. She's written eloquently reasons why she believes it should be legal. But she writes also as a daughter who years ago, her father, 81 years old with metastatic cancer, was going to need to go to the hospital, was terrified about what would happen to him, and killed himself with a gun. And she says, he should have had other choices. And then I'll close with maybe the most eloquent, first, can't superb palliative care, hospice care meet every patient's needs? I think the answer is probably yes for pain and most physical symptoms with right medications. But what patients can't get from me as a palliative care doctor is control over the timing, the planning for what their last days are like. I'd recommend, if you're interested in reading the story of a man who was a front page of the New York Times, where it's legal in Canada, who, knowing that he was dying, organized a celebration while he was alive of his wake, called it his wake, but I got to go. And then the physician administered the lethal medication. He died peacefully, but knowing that the end was going to be on this particular date, having all of his friends, people fly in, spending that time together was a celebration of life that he didn't believe could have happened if he didn't have control over the timing. And then if I can get this to work, I'll close with 3 minutes from Brittany Maynard, who some of you know.
When you realize that you're going to die and then you learn how you're going to die, you have choices to make. And those choices aren't easy.
Brittany was a captivating personality. Everyone who saw her felt she was a friend.
Pay attention to your relationships. Pay attention to what you value, to who you spend time with, to what you choose to make important in your daily life. If something is going to get taken away from you quickly, it's not the stuff of life that's going to matter to you at all. I looked at passing away in hospice care in California, and I really didn't like what that would have looked like for me. I have a tremendous sense of relief now that I've had the prescription filled, and it's in my possession.
It was Brittany that was in control of things, and there was such an amount of relief in that. She didn't have to be terrorized by that tumor any longer.
I decided to share my story, and that wasn't an easy choice to make, but I decided to share it because I felt like this issue of death with dignity is misunderstood by many people in our community and culture.
Brittany's video appeared on people.com first thing in the morning, October 6, 2014. By that afternoon, it broke all the records. Over 400,000 people came to Brittany's website and took action. By the time she died, a little over 3 weeks later, over 100 million people worldwide knew her and knew her cause.
We were all very surprised. We knew that I'm sure it might get some attention, and the point of her speaking up was to hopefully influence, more importantly, move legislators to do something.
The freedom of death with dignity, it exists because it's a choice. I chose this for myself. I would never sit here and tell anyone else that they should choose it for them. But my question is, who thinks that they can sit there and tell me that I don't deserve this choice?
Brittany and I then had that conversation, and she was asking, well, is this something that you want to be involved in? Essentially asking, is this something that you can do? And once we got to that point, then I told her that I would do whatever I possibly could.
So, looking at Brittany, I see a love for life, a reverence for life. The story that you told is of terror about the seizures, lack of control, and then once she knew that it ever got to be too bad, she could, and she ultimately did take this prescription, allowed her a sense of confidence and freedom that had her traveling to Yosemite, going other places, enjoying life with a vividness that was herself and fullness right up to the end because she had this choice. So it's a really hard question about, was writing that prescription about death, or was writing that prescription a profoundly pro-life thing that she did with her doctor? So I'll stop here.
Well, thanks, Lachlan. Thanks to all of you for coming here. As you saw from the first presentation tonight, it illustrates a saying of mine, which is that power corrupts. You've heard that before? And PowerPoint corrupts absolutely. So, so you're not going to get any slides from me. You are going to get some stronger views on the topic, since as you heard, I'm still a clinician. I'm going to start with a recent case, and that's a case of a 55-year-old man with a long-standing history of fairly mild Crohn's disease, who was admitted to hospice care 8 months after he was first diagnosed with a metastatic cancer of his bile ducts called cholangiocarcinoma. And this was after now he had gone through standard chemotherapy and his tumor was progressing. He had had some genetics that indicated he might be a candidate for off-label use of a different drug, but that didn't work for him. The only medicines he was taking at the time he was admitted to hospice were for his Crohn's disease. He was taking a sleeping pill and a narcotic that he could take as needed, but he said he didn't really like taking it because it made him feel weird. He was previously strapping, a former college athlete who had lost 50 pounds over this 8 months. He was extremely cachectic looking. His total bilirubin was 25. He was really jaundiced. He had bilateral biliary drains in each of the 2 branches of his bile ducts, but they really weren't working well anymore, so they had been internalized. The day before he was admitted to hospice, they had done what's called a paracentesis and had drawn off 2 liters of fluid from his cancerous belly. He had moderate pain in the right upper quadrant, but he said what bothered him most was weakness and fatigue, which had previously been, actually in his appetite, which had previously been good, despite the weight loss was now diminished. His voice was weak. He was mentally alert. His prognosis for survival was estimated to be days to weeks. He said to his physician, "I just wish it were all over." Is it wrong to wish I was dead? Now, what would you do if you were his physician? Now, let's assume that you're a compassionate and competent palliative care doctor like Dr. Forrow, and you've probed more deeply into the sources of his concern. And he tells you that all his affairs are in order. He said his goodbyes. He's not depressed. It's just the fatigue, being dependent upon other people, the humiliation of needing a bedpan as a grown man, and the knowledge that all that's left may be the waiting that are the real sources of his suffering. And being diligent, you return 2 days later and his concerns are the same. Now, this is clearly someone who in any of the laws that have been passed in any state in this country or in other nations would be eligible for assisted suicide. So, if you were his physician, what would you do? This is multiple choice. Question A, right? Tell him that you understand how much he's suffering. Assure him that you will not abandon him and you won't do anything to prolong his life 1 second if he doesn't want it. That you're going to help him the best you can with his symptoms. But you also let him know that you recognize why he might want to end his life. That he's suffering a lot right now. And that you respect his autonomy. And that you're willing to write a lethal prescription for him. Or is it answer B? Tell him again that you understand how much he is suffering and assure him you will not abandon him, and also let him know that you will help him as best you can with his symptoms and won't do anything to prolong his life 1 second if he doesn't want it. That you're willing to help him with his bedpan yourself if he needs it. That you understand how much he values his independence, but that at this time he should not be embarrassed. Rather, there's only a need for him to accept the love of those around him who care about him and care for him. That you understand how he feels like death can't come soon enough, but that it really won't be long, and that you remind him that he is cherished, that he will be missed, that his death is going to be a loss, something you're prepared to accept when it comes, but you cannot, as his doctor, force upon his body or let him force upon himself. Now, I take it my task tonight is to convince you that answer A is the wrong ethical choice, and not just for this patient, but for our society, and that answer B is correct. And I'm going to, at least at this point, give you my top 10 reasons. Okay? The first, you'll hear sometimes from the pro-PAS folks that there's no difference between killing and allowing to die. But I think there is. Clinicians know this, and certainly the U.S. Supreme Court agrees that how a patient dies matters, not just the fact that the patient dies, and that there's a difference between stopping a treatment and giving the patient an overdose of a medicine. The key factor is your intention. In allowing a patient to die, the intention is to stop the treatment that you think is needlessly prolonging the patient's dying process. When, for instance, in the famous case of Karen Ann Quinlan, her ventilator was stopped, and to her surprise, she started breathing. The doctors didn't say, oh my gosh, we failed, she's still alive, let's get a pillow and smother her, right? Their intention was to stop the treatment, and that intention was fulfilled when she was not on the ventilator. By contrast, in assisted suicide, the intention is to make the patient dead. And if the patient is still breathing after swallowing the pills, Derek Humphrey, the founder of what is now called Compassion and Choices, recommended putting a plastic bag over the patient's head. The intention is to make the patient dead, and that seems to me to be a difference. Now, why does that make an ethical difference? Number two, because for physicians, killing cannot be stated as a form of healing. The task of medicine, and I hope there are a lot of medical students out here that understand this, is to heal people. And killing is never healing. Assisted suicide, in which you help a patient kill herself, or euthanasia, in which the patient is killed directly, cannot be considered acts of healing. Healing is always restorative and relational. Killing is intentionally destructive and intentionally severs relationships permanently. Allowing to die provides a space for the interpersonal and existential healing that I say, and every palliative care doctor who's really serious about it knows, is possible even in the throes of death. Reason number three, assisted suicide should not be necessary. Why is it that we think we have to have it now when we can do more than has ever been possible in the history of humankind to treat physical symptoms? Indeed, we can use drugs to treat the symptoms even to the point of patient unconsciousness. And if our healthcare system, and you saw some slides from Dr. Forrow, isn't giving that to enough patients, then let's fix the healthcare system, not prescribe suicide. Number four, surveys will show, however, that it actually isn't that patients who actually take assisted suicide are complaining of uncontrolled symptoms, but the real dominant reasons are feelings of dependence, fear of being a burden, loss of control, or even in the Netherlands, tiredness of life. Those are not medical indications. They're social determinations that I think are outside the bounds of medicine. And I don't think physicians should be empowered to make determinations about who lives or dies based on such social determinations. Number five, you heard it argued that we need to do this because patients want it, and we have a duty to respect patient autonomy. But autonomy is not absolute, and it should never be absolute. It has to be seen in the light of other ethical principles, such as beneficence, non-maleficence, integrity, solidarity, and justice. Physicians do not have an obligation to do everything a patient requests, regardless of whether it violates the internal rationality and ethics of medicine. If that's the principle that justifies PAS, I think we're in serious trouble. If it's only the patient's autonomy, then consistency would require we be the same in everything else in medicine, even if it violates what we think is the internal rationality of the practice. There would be no duty, in my view, to provide feudal care, but if you follow that principle, there is. Patient wants it, we have to do it. There is certainly, in my view, no duty to provide sleeping pills simply because the patient asked for them. I don't think we should be practicing Michael Jackson medicine. Number six, some proponents, and you heard this as well, suggest that it's not merely autonomy that undermines the supposed ethical duty to provide assisted suicide, but our duty to relieve suffering. And I agree we should relieve suffering, but one of the proposed standards for assisted suicide then is refractory and intolerable suffering. But peel away the onion when you read how that gets cashed out in the arguments from Dr. Quill and others. Who decides whether the patient is suffering? The autonomous patient. Who decides whether that suffering is intolerable? The autonomous patient. And who decides that it's refractory? Well, even if the doctor says, no, you should try hospice or you should try this, it's the patient who says, that's an unacceptable alternative for me. So it's the autonomous patient who decides. So as you can see, it seems to me there's really only one principle to which the appeal is being made, and that's autonomy. And I just explained to you why I think autonomy alone is not a sufficient justification. What's the other variation on that? Number 7 that's offered? Control. You heard this too. Doctor, I want to die now. I want to control the timing and the manner of my death. Well, I mean, it still sounds to me in a lot of ways like autonomy all over again. But let's look a little more closely at this one. Now, I am certainly not advocating, and never have and never will, that we should run roughshod over the autonomous preferences of patients. Patients have substantial and proper control right now over the dying process. They can control who their doctor is and what treatments to accept. They can refuse life-prolonging treatments. They can name proxy decision makers. They can choose where to die. That's a lot of control. But what does dying by one's own hands add to that control? It doesn't defeat the inevitability of death. If that's the control that's being sought, it's actually illusory. Moreover, if because it's assisted suicide that's being sought, patients wind up ceding a lot of control to physicians who've got to vet the request, certify the patient's eligibility, and write the prescription for the controlled substance. So given that patients could just commit suicide on their own, what is it that it seems to me is driving the need to have doctors do this? It seems to me that what people are really looking for is social approbation. Approval by the state and by the medical profession for what they're doing. But, and here's number 8, it is just such social and medical approbation that, in my view, makes it wrong. Death can be for the best, but it is never okay. It's never okay that we lose a valued member of the human family. We need to remind the dying that they remain valuable, not burdensome, and we shouldn't concur in the judgment that they or we are better off because they're dead. By aiding and abetting suicide, we overturn what I consider to be the bedrock principle of all ethics, the intrinsic dignity of the person and the intrinsic dignity of the patient. That value, the value we each have simply by virtue of being human, is the basis of all rights and all interests. To kill someone or to help someone kill herself commits one to intentionally destroying the bedrock value upon which the claim to suicide rests. You can't respect a person by eliminating that person. And I think in the end, this is why the disability movement is so set against legalizing PAS. They don't expect, at least not yet, to be lined up in wheelchairs and given lethal injections, and that's what the Oregon data shows, that that's not happening. Well, I didn't expect that to happen either. What really bothers them is the bare fact that by these laws, we give social approbation to the idea that either the individual or the world is better off because someone who is dependent upon others is dead. That's an affront to the idea that they have equal dignity, and it should be an affront to our dignity as well. Number 9, PAS just can't be controlled, no matter how much people say it can by law. Inevitably, as it becomes more prevalent, it's going to be charged that it's discriminatory to exclude those who are paralyzed and can't take the pills from having access to physician-inflicted deaths. Equal access will require then that we accept euthanasia because we'd have to do the injection ourselves if the patient is paralyzed. And what about the demented? I think that's what a lot of people fear. I don't want to wind up being demented. Well, if you're not eligible for it if you're early in dementia because you're not terminally ill, and by the time you are eligible for it, because you're terminally ill, you're not eligible because you don't have decision-making capacity and can't do it yourself. So it's going to be argued that it's discriminatory against people who are demented and don't have equal access. And then we'll move to what's called non-voluntary euthanasia. And actually, this is what Marcia Angel, talking about her husband, actually wanted to do. Moving from assisting her father, perhaps with suicide, to euthanizing her own husband. And a bill to do just this, to make proxy decisions at least for assisted suicide, was introduced in the Oregon legislature last year, tabled for now, but more will come. Moreover, it's a troubling time in our healthcare system to be legalizing assisted suicide. Physicians are so stretched for time and so unreflectively willing to simply take the patient's comments at face value that I can't even get my residents in clinic to try to talk somebody into getting a flu shot if they refuse. They come in and say, well, the patient refused, autonomy, that's it, right? Can you imagine we're going to have the complex decisions and conversations that are needed for assisted suicide to be done in the way it's proposed in this environment? It is much easier to write the prescription than to have the conversation or accept one's own limits and the limits of medicine. Number 10, assisted suicide has social ramifications. It is not simply a self-regarding act. A famous liaison psychiatrist from this institution, Ned Kassem, used to ask his patients who were contemplating suicide, in whose skeleton do you intend to leave your closet? When someone is thinking about suicide, it is an act of communication with us and the rest of the world. Suicide is interpersonal, and it deeply affects, in negative ways, even assisted suicide, many families and physicians who witness it. Moreover, the publicity around assisted suicide has proven to lead to copycat suicides among the mentally ill, and rates of suicide in the general population have risen in states where it's been legalized. I think we need less suicide, not more. Assisted suicide, in the end, I think has to be recognized for what it is. And it's an act of violence. Violence is the intentional killing or injuring of oneself or others as an alleged means of solving one's problems. Society needs a profession of medicine that remains steadfastly non-violent. That's why we can't participate in torture or capital punishment, even if we're asked to do so by the state. I believe it's also why we must refuse to participate in euthanasia or assisted suicide, even if it is legalized. And violence can be proposed by people who are soft-spoken and well-intentioned. Violence doesn't need to be gory. In fact, the less gory, the more troubling. As we become distanced from the reality of violence and inured from its troubling consequences, we tend to turn to it more often. Witness the way that modern warfare has become almost a video game. That ought to worry us about assisted suicide. I think we must learn in the care of dying patients to avoid violence as the solution to our problems. Suicide doesn't solve the problems of suffering and death, or change the fact that medicine can't fix those. I think we must learn to avoid the extremes and pursue the sensible middle ground, neither prolonging life unnecessarily, nor snuffing life out deliberately. Neither denying death, nor precipitating death. Rather, we as clinicians must accept death and also accept the fact that we can't fix everything. That's what I think motivates so many physicians. There's got to be something in my black bag that I can do here, instead of humbly recognizing the limits of the craft. We can help people in their dying by rededicating ourselves to providing excellent palliative care, but I don't think we can afford to embark on a course of helping to make our patients dead. Now, that patient I described at the beginning, he died at home in his own bed, surrounded by his wife and children. He didn't receive any more chemotherapy, no IVs, no feeding tubes. When he developed diarrhea the day before he died, he received a bedpan and a little morphine to ease his pain and slow down his bowels. He was not offered a lethal prescription of barbiturates. I think that would have been obscene. His death wasn't pretty, but it was beautiful. Death is rarely pretty, but we should resist the idea that we can make it pretty, because it can be beautiful if we allow it to unfold before us. If we learn to accept the limits of medicine, accept the inevitability of death, help our patients' symptoms and accompany them as they are dying, but never accept that it's good to deliberately make them dead. I think we owe that to society and to our profession, and above all, to our patients. Thank you.
So I'm just gonna, can you hear me? Is my mic still on? Great. A couple of comments really, but to make this a conversation. As I said from the beginning, so my job as framing the big picture, setting some context about care near the end of life and our challenges, and I said I think this is like the 0.3% issue. But let me say a couple things personally. Much, absolutely not all of what Dan said. If you were looking, I was nodding. Couple of facts. In my own personal experience of 20 years at Beth Israel Deaconess and lots of patients called either in my palliative care or ethics role, I've been called for a bunch of patients who had voiced wish to end their life when they had a terminal illness, sometimes in my ethics role, sometimes in my palliative care role. So far, in 100% of the cases, when I got there and we're talking to them, they were serious. What they saw ahead, they never wanted to go through. If they could, they wanted their life over. As I listened, understood more about what they worried about, what they might hope for, if actually things weren't so bad, in 100% of those cases, the person stopped expressing a preference for suicide, and with family support, we're focusing on the things that could have life be worth living for additional time. Skeptic would say, oh, maybe they thought that I was hot, like I wasn't letting them talk about it, and they knew they had no choice and all that, and I'm open to that possibility, but I honestly don't think so. I think that the fundamental problem for all of them was they had a devastating illness. They were terrified about the future. It was possible that there would be pain, loss of dignity, loneliness, all of those things. But in fact, almost all the things that they worried about with the right medical treatments that are better than in the history of medicine now for symptom management, with the right human support, with some help from me or a social worker or a pastoral care person and talking with their family, talking about being loved, am I going to be a burden, all of those things, they didn't choose this. And I actually like to think that even if it were legal, if we'd been able to actually go through that process, they wouldn't have chosen it. I thought I had my first a number of years ago. I was telling Dan earlier, when there was a patient with advanced pancreatic cancer, was going to die within the next month or two no matter what, was losing weight and was done. He was absolutely informed, understood his choices, would have moved to Oregon if he could. I explained to him all the options, including he could stop taking in any fluids. He would not live more than 2 weeks. Be less than that because of other medical reasons. Went by the next couple of days and he was not taking in any fluids. Right? And he thought he was totally calm, like I'm done. I told the nurse practitioner working with me, I've just had my first exception. I went back the third day. He's got this big thing of water, and he's just drinking it and drinking. And I look, what are you doing? Just like, I got to know. He said, I've been thinking about what we've been talking about, Dr. Forrow, and you're right. My granddaughter in California, I haven't seen her in a while. I'd like to see her one more time. And, I want to be in good shape for her visit. She can't come for another week or so. So even he, but it took some time and reflection and came to a different place about this. So it worries me if legalization happens. This is an easy thing to do. Patients who are scared, terrified, don't want to be a burden, don't know how to talk with their families, have this option. A well-meaning doctor who has limited time to spend, that scares me. But I don't personally think that having it be illegal is the only approach to this. We need, whether it's legal or not, we need to have people who have the skill to be able to help this person. The one other comment that I would have, and we can talk some about this, is it is so hard to find language about this that is not inflammatory, that actually helps our thinking. So I cringed, Dan, at each time you called this killing, even though, for me, it's an absolutely fundamental issue that the goal of the patient being dead, I just rebel against. Right? That's not the goal. Comfort, all the goal of the patient being dead. But killing in our brains connects to all kinds of things that are actually radically different from what Brittany Maynard's physician did for her. And I would love to think of medicine as a nonviolent field, but go to any of our hospitals, we do all kinds of violent things. And I don't think violence is at all the right word for what Brittany Maynard's bedroom, the day that she took the prescription, fell gently to sleep with her husband and her mother there. I don't think violence is the right word. So it's hard to find words to help us think through these things that aren't inflammatory and maybe make us think less clearly.
Well, thanks. No, it's good to have the conversation here. And again, I appreciate that tone that we're trying to establish here, that we can talk to each other about these issues. Let me say first that I, again, agree 100% that the main issue quite often is to get to the root of what the request is from the patient. I remember, similarly, another anecdote here of a case of a patient whose brother was demanding that we euthanize his brother, it turned out that when we pushed it, that the real reason was that the brother of the patient who was dying was actually disabled and would have grave difficulty because the insurance company was going to, if the patient was put into hospice, move him to someplace, and this was in New York, to Staten Island when the brother lived in the Bronx. And it would be incredibly difficult for him to get to visit him. And that was the real reason he wanted euthanasia, was so he could be there when his brother died and be with him. And so, if that's the problem, what did we do? We didn't say, here's the prescription, right? We sort of said, we'll work with the insurance company. We got the insurance company to say they would pay the hospital the hospice rate to have the patient stay in the hospital, and the patient died with his brother at his side in the hospital. So I think it is clear at a clinical level, and we both agree with this 100%, that you really need to sort of figure out what the patient's what the real source is behind the cry for assisted suicide, and try to find out what the options are to help with the patient. Second, I think we both agree this is an enormous distraction from the real work that needs to be done to improve access to good palliative care for everyone, and in some cases, access just to care. So Richard Payne, who you may know, palliative care doc, was at Memorial Sloan Kettering and tried to start a hospice program in Harlem. And he was enormously rebuffed by the community there. They said, sure, you're going to give us morphine when we're dying from coming from Memorial Sloan Kettering, but you're not giving us access to the cancer care from Memorial Sloan Kettering first, right? So there are huge problems with access to care, with access to good hospice care, that this is an enormous distraction from. And to spend the amount of time that we have to on this, I think is really significant and problematic. With respect to violence, or respect to killing and respect to language, I think I'm after clarity about what it is we're actually doing, and honesty in our language. And I wonder what people are trying to hide when they call something like this aid in dying. They don't even want to use the term suicide, saying that that's stigmatizing somehow. If you look at it, even the laws, and I don't know what's in the bill in Massachusetts, but the laws say that you're supposed to put the cause of death on the death certificate as being the underlying cause of the underlying illness of the patient, and not assisted suicide. I mean, that seems to me to be incredibly dishonest about what's actually going on. Killing, for me, is simply a term that describes what's actually happening, to create a new lethal pathophysiologic state with the explicit intention of making the individual dead. And that applies to a mosquito as well as to a human being. It's simply the descriptive term, and I don't want us to sort of cover that over with all kinds of other terms, or obscure the word suicide, as if that weren't actually what the patient is doing. So I don't want us to be fooled by people resorting to euphemisms, which I think they often do when they want to sort of cover something up. And that can happen when they can't really convince you with ongoing, straightforward ethical arguments. Aid in dying, what does that mean? I think I aid a lot of patients in dying, and I think you do too, all right? Discontinuing ventilators could be that. Stop giving somebody opioids that may hasten their death could be that. But it could also be euthanasia too. So what does this word actually mean, if not to obscure? So that's the reason I'm trying to use clearer language, and not to obscure it with terms that I think are moving us away from inuring us to the reality of what we're actually doing.
Thank you, both of you. My first question is to Lachlan, and it's one that some of the organizers of the forum in advance wanted to raise, and that is that opponents of PAS often are concerned that if this becomes available, it would contribute to or promote a societal belief that illness and suffering have no greater purpose or meaning. And on this perspective, life might not be seen as something that has inherent value, apart from some sort of utilitarian calculus of one's potential for pleasure or for productivity, and that just outweighs the suffering or being a burden on the world. As you know, persons from the disability group, persons with disabilities in particular, have expressed worries or concerns that legalization of physician-aided dying would lead society to place less value on their lives, and that they might face some sort of psychological or even economic pressure to end their lives early. What are your thoughts on that worry?
Let me reframe it a little bit. I think in these questions is actually, in some ways, one of the most important, profound, fundamental, crucial aspects of this whole issue, which is about, the fact 100% of us are mortal. What's that last part of our life like? But also, what gives life meaning and what counts as dignity, those things. And it's really complicated even to think about that some, because so much of what each of us really believes about our lives, so it's like, it's my belief, is internalized from the societies that we've lived in. one of the most profound understandings that I've had about race issues was a student who spent time in South Africa a long, long time ago, and she's actually Asian American, and she's in line, and this black South African said, "No, you have to go ahead." An older man, and she's saying no, and it was so clear to her, she was telling me years later in tears, that he did not believe that he was worth as much as her. Right? Not because society for it, but just like, so who we become. A couple years ago in a panel here, I pointed out one of the longtime staff at Harvard Medical School, not a doctor, whose family's from Africa, listening to all these conversations said, you know, it's just this word dignity, the way you guys are talking about it, was actually Marcia Angel here, and life, and it's undignified, and all of those things, says, where I grew up in Africa, what you described, this frail elderly man who's incontinent, who can barely get out of bed, and then he's standing up, he's about to fall over, and he's having trouble thinking clearly. When that was a village elder, that was the pinnacle of dignity for us. Despite all of those physical frailties, this elder was showing us what human dignity is, and you're describing this and saying, oh, that's the opposite of dignity. Right? There's some real worries that I have that thinking about this, and I spend some time listening to people with disabilities. The previous time there were hearings at the State House, there's somebody there from Syracuse, a professor at Syracuse University, I believe, quadriplegic with a neck injury from years ago, who described being in the hospital. He's otherwise well, being in the hospital. He'd had pneumonia. It was a difficult kind of course, and this young doctor coming in, completely well-meaning, reassuring him that he didn't have to suffer, they could keep him comfortable, totally clear that this caring doctor thought that he must be suffering terribly. He said, I wanted to scream at the guy. I had to just not be, I had to be direct. Said, excuse me, I'm a professor at the university here. I'm eager to get back to my classes. My life is really worth living. You know, I've never known anybody who found pneumonia an enjoyable kind of thing. You know, please take care of me the way you take care of everybody else. Right? And it wasn't anybody trying to force something on him. So I think that as we're thinking not specifically about legalizing physician-assisted suicide, but about human beings and mortality, we need to actually have real questions ourselves and in our families about what it means that for almost all of us in the beginning of our life, we're totally dependent, and that's how we experience love and our parents express love. The latter part of our lives, we often become more dependent, and for some people that's totally embarrassing, shameful. For other people, it's a period where families express the deepest love and meaning and support, and actually realize that my dignity and my worth isn't the productivity of the job, it's the love I had for my family. I think we need to be talking openly and honestly about that, and insidiously, if we don't, we will have choices, not just physician suicide, but I wouldn't want to have the curative cancer treatment because I'm going to be a burden to my family. We need to talk more about this.
Dan, actually, I have a question for you that helps go a little bit more into dignity.
Okay,
so
maybe I'm already anticipating it, so go ahead.
Opponents of PAS often come from a perspective that life has meaning, that persons have intrinsic dignity, and some even believe that suffering has redemptive purposes. However, individual patients may not share these beliefs. Some believe that there is no ultimate meaning or purpose in their illness or pain, and they want to die on their own terms. Why should those who believe that persons have intrinsic dignity or that suffering has purpose impose that worldview on those who do not, by not allowing them the legal option to die the way they want to?
Well, yeah, it basically does lead to the comments I was going to make. I draw a distinction, and it sort of helps to make sense of the anecdote from Africa, between two uses of the word dignity. One is an intrinsic sense of dignity, and the other is an attributed sense of dignity. The intrinsic sense is the one that's used typically by the opponents of assisted suicide, who will say that all people have a value by virtue of being human, right? That this is a good way it was used by Martin Luther King during the Civil Rights Movement, who made copious use of the word dignity, who said he learned about its meaning from his grandmother, who said to him, "Martin, don't let anybody ever tell you you're not a somebody." that being somebody and the conviction that every one of us, every one of our patients is a somebody is what we mean by that sense of dignity. The value that persons have prior to interests, prior to rights, right? Attributed dignity is another way we use the word. When we talk about somebody visiting from another country, we call them a visiting dignitary, right? We attribute value to people. We say that doing windows is beneath my dignity, right? Doing those, or that in these sorts of cases, being incontinent is beneath my dignity. Being dependent on other people is beneath my dignity, right? And those are sort of either attributions we make to other people about their relative worth, or we make about ourselves in a social context. Now, are those simply two competing uses of the word? Well, no, because logically and linguistically, you don't use the attributed sense of dignity unless you already understand the individual about whom you're speaking to have an intrinsic value, an intrinsic worth that we call dignity. We don't talk about different kinds of soil being beneath the dignity of a snail, right? We talk about this being beneath my dignity or an affront to my dignity as a person. There is no question that serious illness and dying mount a relentless assault on the attributed dignity of people. They lose their productivity. They appear different to people who shun them. They may even begin to doubt their own self-worth. So that one of the fundamental questions then, as Forrow was suggesting, about what kind of a society we are, is whether we ever believe that that assault can be total, that it ever robs people of their intrinsic worth. And in this sense, I think we have to commit ourselves to the suggestion that no circumstances, not how other people look at you can, or how productive you are, can rob you of your intrinsic dignity, because it's the bedrock of all of ethics. And so in that sense, I think that even if a person asks for it, we have to say no, because we are social beings. We are I was going to say created in the image and the likeness of God. That's a religious way of understanding what this intrinsic value is. But I think even independent of that, Wittgenstein once wrote that if suicide is allowed, anything is allowed. Because I think he understood the sort of sense that the bedrock of ethics is the sense that people have this intrinsic worth, and we can't allow that to be diminished within society if it's going to function well.
I'd like to go back into further into individuals and their values and their goals. Lachlan, when I've done ethics consults in the past, I probably every week would quote something that I attribute to you that goes something to the effect of the patient and the family are the experts on that patient's values and goals, and the clinicians are the experts on which clinical intervention should be offered to try to attain reasonable goals. We can't tell the patients what their values should be, but we can talk about the goals. I think, is that a reasonable?
Close.
Okay.
Close, yeah.
So we have a patient in front of us who's expressing their values and their goals about their end of life, and perhaps they are toying with this idea or wondering about the physician-assisted suicide. And you could say you're in Massachusetts or you're in California, and you're now bringing your clinical expertise to this situation. How do you explore their values, and let's say both their sort of their own attributed one, and you yourself have referenced Dr. Schweitzer with Reverence for Life in terms of their intrinsic value. And what clinical interventions do you propose to meet those values?
Sort of try to be, you may have said, a KISS, keep it simple, stupid person, and basically in this decision-making, patient, family, the patient or the family on behalf of the patient is really the expert authority about what's important to them in their life. It's not the doctor's job to say this is what's good about your life or not. but the doctor is the one who decides, can I actually accomplish that for you for things medically? What's the best way to do that? It's not up to the patient to say, I want this antibiotic or that antibiotic, because the framework. But having said that, and this would echo and support some of the things that Dan was trying to say, the doctor is not just a technician. And it was actually a Harvard medical student years ago when I'd drawn this and thought this was all explaining things, said, oh, so if the patient said, what I would like is a bolus of IV potassium to end my life right now, this model you had, Professor Forrow, says you would draw up the needle and you would give the injection and kill the patient. And I go, well, actually, no, and sort of backtrack. Doctors have values too. And if a patient is asking something or even has values and goals that require me to treat that person in a way that could be medically, I think isn't going to be helpful, but sticking with the values, that means is asking to be treated in a way that I as a doctor, or individual as a person, I think that there's a better way of treating you. I'm not obligated to accept your values for my own any more than you're obligated to actually be the victim of my values. So I think in any circumstance, in terms of possibly dangerous but maybe helpful, provocative kind of language, I think there are enormous parallels, at least for me in my thinking about this, and abortion. Right? As I testified to the legislature a number of years ago, I said I'm going to make everybody upset when I say this, but the focus on people have to have the right to suicide. Said, I've done a lot of work in Africa. There are women in Africa that when they get pregnant, they're terrified. They might already have some kids because women die in childbirth. If the baby is born, it may die during the delivery. If the baby survives, it may die of malaria because there are no meds. All these, they're terrified of the pregnancy for all kinds of reasons that we actually could take away. Somebody going in there and saying, oh, the issue is here, they need a right to abortion. Said, I actually believe a woman should have a right to control things in her body, but it's not even a meaningful right if she doesn't have access to all those other things. In the United States, where people are scared of a terminal illness and dying and pain and all of those things, that before I actually even want to have a conversation about this option of last resort, I want to make sure that they don't have those fears about things. But even if there's a situation where the patient there by themselves considers their life undignified in this condition, I think personally, my own personal bias, my job is to try to help them see the dignity that I think they have that they're not seeing, not to enable or support their belief, which I think is mistaken, that their human life is no longer worth living. Right? I might fail in that. I might get to a point where tragically all that's happening is I'm prolonging their suffering and I'd have to figure out what to do, but that's the last resort. I believe in Schweitzer language that every person, no matter what their medical condition, human condition, has the intrinsic dignity, is worthy of our reverence, our help for them if they're vulnerable, and if they are so suffering that they don't even believe they have any value at all, that just makes our obligation to try to express their value to them even greater. It would be the opposite of, oh, you've convinced me that you're totally convinced your life has no value, therefore I'm going to go along with you. My reaction should be the opposite, I think, as a doctor.
I'm curious to know how this looks like practically. I'm going to ask another question perhaps to both of you. Dan, you've written about Ars Moriendi, the art of dying, and you ran a project on how do we enhance the life of the dying. What does that look like? One-on-one with a patient in the room, in your office, in his home, or home. What does that look like? What does it sound like? How long does it take? How many visits? How do you bring this out? Both of you, Ars Moriendi,
Sure.
And practically playing out what you've described also, Lachlan.
Sure. Let me first start by ratifying a few things that Lachlan just said, which I agree with 100%. That the sort of sense of the patient saying that my life has lost its value is something a clinician should never ratify, never ever ratify. and to write the prescription becomes de facto a ratification of that. I would differ slightly in that I don't think that we can point out to them what that value is. What we can point out to them, I think, is that we continue to value them, even if nobody else does, which is precisely the reason why I would not actually engage in writing a lethal prescription for the patient. And it's not just my values, but I think it's the value of society, it's the meaning of being a professional, it's the meaning of all of ethics that we bring to the table. And that's why this is so critical, I think, an issue. So what is it? What does it look like? I think it means something like the case I started with. It means here, I'll help you with the bedpan.
How
Right?
practical is that?
It is.
For the guy who's living in Roxbury, several
well,
blocks away,
well, if
neighborhoods
you're,
away.
okay, well, you can't do it there. But I'm saying if you're one-on-one, right? If I'm with the patient, right, and the nurse, I think that's part of how you show that kind of respect for the person's dignity is by not running away from the messiness of it or trying to cover it over, or saying that your life is so valuable and you are so important to me and worthy of my time. That I'm not going to go say, well, I'll get the nurse who's busy caring for somebody else to come do this, but I will do it. If we're willing to be as concrete as that in showing our respect and love for patients, that's what it means at the bedside. That's what it means, and it doesn't mean giving patients lethal prescriptions. It means showing, another Wittgensteinian phrase is shown, not said. That's what it means. Shown, not said. That's the kind of care that patients deserve from our healthcare system. And when they're out in Roxbury, again, we've talked about it's not just at the bedside, it's developing a system that can prepare patients and serve patients in their needs wherever they are. And not just in the suburbs, but as you were challenging the Archdiocese, build the hospice here, bring more Missionary Sisters of Charity into Boston to have the hospice here open to anybody who's dying, to care for them and show them the respect in those very concrete ways.
It would cost less money than many of the things that we do that I think are violent and undignified.
And Lachlan, if you were in California, Vermont, Oregon, Washington, and the legal option was on the table, and you were engaging with this patient even up to, what does it look like even before up to that option, or while thinking about that option? How are you exploring with them their values, their goals, their sense of being a burden on others?
I guess I don't have a formula, but part of this is requires relationships between the patient and the doctor or the nurse practitioner or the social worker that, at least in our teaching hospitals, are so often transient and not there that it's like really, really hard. But think of two patients right now that I've seen, but over time, and then they're readmitted, I've really gotten to know them, and they're struggling with something, and I look at them and say, I don't think you're ready for that, for hospice yet. I know you. I think you're just having a bad day. We're talking in that way, and they're hearing that from me, and they say, and then the next day say, Doc, you were right. Right? I mean, these aren't simple things of like somebody coming in and just explaining things. It's you're there with the person, understanding, grappling, trying to understand if from there or through their eyes they could actually see things in a different kind of way. I don't have a simple formula for that, but it takes really, intensive longitudinal relationships without which I actually don't think human beings can get the kind of care through this that they really need, which is a whole other health system issue.
We're now at the last half hour, and we have been receiving texted questions that are being collated off the side for me. I have them up now on my screen. I'll begin to give them to you.
This is very high tech.
Very high tech. And I think you're still allowed to continue to text them in from this room, and also, hello, you all. in the live stream rooms. We wish you could be here with us. Dr. Sulmasy, how is allowing a patient not to eat, have fluids, or have chemotherapy not a form of violence? Keying in on your word choice.
Yeah,
there.
sure. Well, first of all, I think that those, if a patient, we have to distinguish at least the several things are contained within that. Most patients who are dying naturally stop eating and drinking. It's part of the natural dying process for many of them. It is different from something which is being proposed as an alternative to physician-assisted suicide called voluntarily stopping eating and drinking, where a patient can eat, has no circulating cachexins, end stages of illness that are distorting their appetite, no obstruction to mastication or swallowing or digestion, et cetera, and chooses voluntarily to stop eating. If they do that, that's an act of suicide, which in my view is an act of, as I suggested it, violence, which is using destruction of one's function or one's entire life, in this case, in order to try to escape from one's problems. Similarly, in the case of someone who is dependent upon machinery, there is a difference between letting a natural, the natural evolution of a disease take its course or refraining from continuing some treatment that was interfering with that natural history and deliberately creating a new lethal pathophysiologic state with a specific intention in acting of making the patient dead as the escape from his or her problems. So that's how I would parse them out using the language that I'm using. And I think that, I mean, how many people here have been at the bedside when somebody died? That's more than most places. That's a good number. It's as I said, never pretty, but it can be beautiful. And I don't think I characterize that as violent. Even the death rattle may be threatening to us, but I think is part of what we have to understand is happening to somebody we love and who we cherish, who is gradually slipping away from us. And that's not a violent place, the bedside of someone who's dying naturally.
Thank you. I'm going to combine two parallel questions, one from a nursing student and the other one from a pediatric oncology nurse. If the patient cannot communicate their desire for PAS due to not being able to move or talk, is it still possible for the patient to receive PAS? And I think a parallel question is, how would PAS affect the pediatric population with terminal illnesses? Who would make the decision to end their lives if children can't comprehend PAS? Either of you.
I'm going to take the easy, I know it's the easy part. But, first, I'm not involved with kids, and I wouldn't even start to comment. I really think really understanding children, parents, and all of that requires, I'm not going to even comment on kids. There's a real, I think, ethics consistency, whatever kind of problem in the laws in the United States, including in Oregon, which require that the patient be able to self-administer a medication. You can see in longer tapes of Brittany Maynard, she took the medication when she still was mostly enjoying life, in part because she had decided that her great terror was she might actually have a stroke from the tumor, then be unable to take the medication, and then suffer this indignity from her perspective. And so in order to make sure that the last part of her life was the way she wanted, she was going to have to take the medication when life was still actually not too bad. Additional problems of patients with cervical spine injuries or ALS or other things who are not able to self-administer the medication. None of these laws are excluded, so there are challenges about that. There are people who have written about if I need to be competent in real time to be able to take the medication, that if I'm diagnosed with early dementia, I'm going to take the medication when I'm still competent, even though I value life, because if I don't, under these laws, once I'm no longer competent, I'm going to be sentenced to that long kind of trajectory. So I'm not at all sure that if we are going to allow this as an option at all, that we wouldn't actually have some people choosing to live longer if we allowed for the possibility of someone else administering the medication. That's just one of the dimensions of complexities in this.
Yeah, I'd add to that I tried to make this point within my own very rapid set of 10, that this is part of why the argument that the United States can keep laws limited to assisted suicide is just not going to last very long. It will not be possible. And there's already pressure beginning to do exactly this, because it is, if you say this is something that people ought to have access to, then in fact it is discriminatory to say that somebody who is demented can't have access to it, or that someone who is paralyzed can't have access to it. And that's why there will inevitably be legal pressure to push, once enough states have legalized this, to legalize euthanasia, and then to legalize it by proxy as well. And that's why most of the European, and the other reason is that it's simply more efficient. We are actually better at, I won't use the word killing, at ending the lives of patients than the patients themselves. Because sometimes when people take the pills, they vomit, it doesn't kill them because they might be actually more tolerant than they thought of the medicines, et cetera. And so there's then pressure to sort of complete suicides as well, and it's more efficient to have the physician do it. And that's why the European countries that have both, like Belgium and the Netherlands, it's almost all euthanasia and no assisted suicide.
And my sense is Canada so far is that way too.
Is moving that way very
where it's legal for the physician to administer the medication that the patient has requested, and that's actually what most often happens.
And then the pediatric aspect of it, again, has not happened in this country where it remains illegal, but the same pressures exist, and they already have pediatric euthanasia in the Netherlands, something called the Groningen Protocol, where patients who are born with spina bifida can be euthanized in the neonatal setting. And I think there will be, again, pressure in that direction. And while there is a small number of people who want this in the United States right now, the percent of all deaths in Belgium by assisted suicide, or mostly euthanasia, is now 5%. 1 out of 20 people in Belgium are dying.
Not 3 out of 1,000.
No, it's 1 out of 20 who are dying at the physician's hand. And I think, again, once we medicalize this, make it more acceptable, then the pressure, the default switch flips, right? The pressure comes on the person, why haven't you availed yourself yet of this right, rather than being something that is the rare exception.
Drilling down on the word suicide, an undergraduate student writes, as a mentally ill person who has been suicidal in the past, I disagree that PAS for terminal illness is equal to suicide related to mental illness. Thoughts?
When there was a panel here a couple years ago, and Compassionate Choices, I think, President, the slide, suicide, red line, this is not suicide. And I'm sort of listening because it's so different from a young person with mental illness. It absolutely is different from a young person with mental illness, but on my iPad or whatever, I found like 8 different online dictionaries, and then I raised my hand with the question. I said, every dictionary I can find in the world said the word suicide means the deliberate taking, ending of one's own life. To say that this is not suicide, I think, is Orwellian. It's like changing the meaning of words. It is a radically different ending of one's own life, which is going to end anyway soon from a terminal illness, from a young person with mental illness. But I think the word suicide is what it is.
We're in total agreement on that score in terms of the use of the word. The question then becomes, whether we ought to legalize this form of suicide. And we ought to just be honest about saying that's what the debate is.
And there have been different cultures historically around the world, different places where, given one's circumstances, suicide was a deeply honorable way of showing your debt to society. You committed a crime, or just like you didn't wait to be executed. So to say that this is literally suicide still leaves us with all the questions, all the moral and other kind of questions about it. But to say it's not suicide, I think, is making it hard to actually have honest, clear discussions about what it is.
About the general topic, somebody writes, I'm a Christian. Are either of you religious, and does your faith affect your view?
So I was saying to Alex earlier, raised Episcopalian, Catholic wedding, children baptized Episcopalian, took them into a Unitarian church, end up, in terms of faith matters, Albert Schweitzer, I liked, said, spirit unites. I think there are some very spiritual aspects about the way I view the, what it's like to be human and all of that. But he said, spirit unites, dogma divides. There is no religious creed or organization that I actually consider myself a part of. I don't think that my views on this have anything to do with a specific religious affiliation, because I don't have one. I do believe that my views about how sacred human life and actual life is, if anything is, that word sacred is a difficult word, come out of the Judeo-Christian tradition, and as I said, Schweitzer found it in Buddhism and other traditions as well.
Yeah, I'm a Christian, a Roman Catholic, and I guess in many ways our Catholic Christian way of thinking about ethical issues makes it fairly easy to talk to people of all faiths and of no faith, because we subscribe to the view that God gave everyone the gifts of reason and the possibility of goodwill, and that we're able to talk to each other and reason out these kinds of questions. My degree is in philosophy, and that's how I tend to make the arguments about these issues. If you want to speak within the Christian fold, specifically about this question of suicide, there are plenty of things that have been written on it, sources I could turn you to. This is sort of in the keep it simple, stupid category, but my way of talking about, for instance, Aquinas's view of why suicide is wrong is that it's ungrateful, unnatural, and antisocial. It's ungrateful because in Aquinas's view, God gave everyone the gift of life, and only God can take it away. It's unnatural in the sense that what is had the gift of life life has within itself, while it contains the seeds of its own destruction, also a striving forward that shouldn't be subverted. And it's antisocial, which is actually an argument that he really borrowed from Aristotle, who wasn't a Christian, which is that we are all connected to each other, and that we all suffer if one of us takes our own life, and that we have to be careful never to do that, because we're part of a community which is, in Aquinas' view, of God's creation. So that's one sort of Christian take on the question of suicide. And then if suicide is wrong, obviously physician assistance in that activity would also follow as being wrong.
And if I'm going to add to this for myself, if you're consciously objecting to participation in PAS as a provider, and you were in a state that allowed it, if you were opposed to it, what would be your thoughts on referring to a doctor who is willing to carry out PAS? Which was also a specific question.
I think that's going to be a real challenge my understanding of the current bill in the Massachusetts legislature, there was at least testimony from a Catholic nurse practitioner, I believe, who said interpretation of the language was that you would not only be required if you were Catholic in a Catholic facility that had objections, you'd be required to actually pay the expenses of the person transferring other things in ways that are really difficult. I think this is a hard, difficult challenge. In terms of religious objections, in the example of abortion, my model goal, and I don't know the details of how to do this, is what my hospital, Beth Israel Deaconess, when it was Beth Israel Hospital under its OB chair, Ben Sachs' view about abortion. He had the question about whether or not interns applying for his internship in obstetrics should be required to do abortion. And his conclusion was, Brigham and Women's Hospital policy had always been, no, it's part of the job description. If you're not going to do abortions, don't come here. He said Beth Israel Hospital was founded because there was, in large part, religious discrimination against Jewish doctors and patients and other things. That's why we exist. He said, for me, even though I'm Jewish, to discriminate against people based on a faith-related view, like question about abortion, that would violate the whole founding ethos of our hospital. At the same time, he said, our hospital is committed to a woman's right to choose, to access, and to training people for the future so that that right means something. So if you come to our hospital, then our patients, every patient here has got to experience, every woman, that if she has a pregnancy, she has a right to abortion, cannot experience you as in any way doubting a barrier to that, and it's a challenge, right? Somebody answering the phone who has this view has to be able to say, excuse me, someone else got to take your call, I've got to go run something. Like, I think we need to find in a pluralistic society for things like even pharmacists dispensing, the Plan B. We have to find ways in which people's deep religious faith convictions can be respected, and yet the customers at the pharmacy or the patients at our facilities are experiencing only respect for theirs. And it's easy to say, but I actually believe it will be possible to do.
A medical student writes, how does being made in the image of God actually compel one not to use PAS? I hear this argument, but I'm not convinced. Didn't Jesus choose to die for a purpose? We're getting into it now. Let's go.
I was actually going to ask Dan that same question. So, just upping the ante a little bit, but just one of the things that I find most helpful to hand to Catholic patients who often do not understand Catholic teachings. Pope John Paul II, hardly a flaming liberal, wrote a wonderful encyclical titled On Euthanasia. Most of it was condemning suicide and euthanasia for reasons that are predictable. The last section I just find profound and beautiful, which says, a Christian of good faith can decline medical interventions if, from his or her perspective, the burdens would exceed the benefits, and then says, including burdens on family or society. Right? And he says, such a decision is not the moral equivalent of suicide. It is a decision to place one's life in God's hands, accept the human condition, because this life is a life of infinite value from God, but it is not the gift of ultimate value, which is the life hereafter with Jesus. It's just a beautiful kind of passage. So leaving aside the complete condemnation of suicide, I can imagine if maybe one day I'll rediscover my Christian faith, as an Episcopalian, close enough to Catholics, I can imagine being a devout Christian with all the beliefs that go along with that, and believing that my longer life is going to involve burdens on family or society and costs for some period of time that I do not believe, given the injustices and the unmet health needs, are the right thing. I can imagine, out of Christian faith, choosing to have my life end sooner And it'll be a little bit of a stretch to say through suicide, through taking a prescription, as an act of Christian charity, kindness for the people around me. I can imagine as a Christian doing that.
Well, it's going to be hard to top a former Episcopalian quoting John Paul II if I'm the first person who's supposed to talk for the Catholics. But let me say this: that Roman Catholics invented the term extraordinary means about 500 years ago. And it just meant in those days that if the doctor told you you were, sick and you should move from Sicily to the Alps because the atmosphere would be better for you, and you said, well, I'm poor and, I'd be separated from my family and I'd use all the money to do that, that would be an extraordinary or morally optional treatment prescription from the doctor, and you wouldn't have to do it. And the reason is that the view is that life is a gift. Life is a gift from God, and one is required to be a responsible steward of that gift. But one is also human and mortal, and one only has to take measures up to a point. It's the same with duties, any positive duty of the moral law, like the duty to be charitable. It only goes up to a certain point, and then afterwards, you don't have to do more than sort of what's sort of reasonably required of you. You're a saint if you go over that, and you can, but you don't have to, right? So it's in that light. Now, why is it that the death of Jesus is not suicide? In some ways, the best answer for this, if you want to really read seriously about it, is given very early on by St. Augustine in the City of God. I think it's in book 3, in which he's trying to argue about why it is that people who, at his time, were deliberately provoking the Romans into killing them by saying, "Hey, I'm a Christian. I'm not going to worship the emperor. Kill me if you want to." Were not true martyrs. Okay. And the reason that was given was that you can accept your death, right? When the choice is either to accept death or flee from death in the face of a choice that would require you to love or to do what the faith requires of you. Then it's a sort of passive acceptance of your death as the requirement of obeying the law to love or obeying the law to worship. If you try to provoke your own death, even to get into heaven, right, then you are actually deliberately making yourself dead, and that actually is the form of the difference between allowing to die and killing. And so even before we had the advent of trying to discuss this about ventilators, the difference between accepting a death which is inevitable or deliberately provoking your death, even for what you consider to be a good means, is the difference between killing and allowing to die. Jesus did not commit suicide, right? Jesus said, if the price of, in this case, standing for love and the salvation of the world is my death, then I accept that. But Jesus did not kill himself. He was killed by the Roman authorities.
We have 5 more minutes, and I want to do two questions. Both of you acknowledge the need to have difficult, messy conversations to convince patients to live. For pro-PAS, at what point do we write the prescription?
Just to add complexity, as I have learned more about what's really happened in Oregon and other places, and actually watched Brittany Maynard's story, in Oregon, between 30 and 40% of people who get the prescription never take it, ever. Another chunk of them get the prescription and don't take it for quite a while. think you saw some in the Brittany Maynard thing, is what having the prescription does for them is takes away the fear, the terror, the anxiety, and allows them to then live more fully than they otherwise would have been. And for 30, 40% of them, they never take it. So when you write the prescription, if I was, and again, I have never had a patient yet for whom, even looking back, if it was legal, I think writing the prescription would have been the right thing. But if I'm busy enough, I can imagine that. But I can imagine most commonly having a patient who is worried, scared about all those things, and getting to the point where you say, you know what, I'll write you the prescription, but you'll have the prescription. My goal is going to be you will never have a reason to take it. And now you have the prescription, and I can imagine that as a deeply pro-life act. I'll stop there.
I'd sort of counter by saying that another way of saying that 30 to 40% of patients don't take the prescription is that my treatment only kills 60 to 70% of my patients. And I think most of us would consider that to be not a good therapy and something that we wouldn't actually engage in. And particularly, obviously, if you think that physicians should not be intentionally ending the lives of patients. Second, just, Lachlan, I appreciate you showed the film from at the end of your talk, and I appreciate how you've been moved by the Brittany Maynard story. But I think we all have to realize, who paid for that film? Who put the music in the background? Who produced it? It was Compassion and Choices, the leading organization in this country promoting assisted suicide. That probably has people in the audience. They usually have at least one or two every time I speak anywhere who are there to ask me nasty questions. But that's, you've got to be careful about how that really is she's being sort of used as the poster child for this in a political gambit. And I think maybe she was willing to participate in that, but I think we have to recognize what's behind all that.
I want you two to have an opportunity to leave challenges for the medical students and others in the audience. This is the Veritas Forum. Veritas means truth. It's on the Harvard shield. It's the Harvard motto. You may know or may not know that the original Harvard shield had 3 books on it. The current Harvard shield has 3 books on it. All 3 are turned up. The original Harvard shield had 2 books up and 1 down, as though not all truth was revealed yet. And at some point in Harvard's illustrious history, they flipped the book around. So, has all truth been revealed? So, are there no more mysteries to uncover? What mysteries, secrets, untruths, uncertainties, doubts, or challenges concern, intrigue, excite, or worry you about this issue? What challenge do you want them to go out and truth that they still need to seek?
I'm actually going to, I don't know this, avoid the question, but my last, I'll say what I think the challenge is, and it's, I'll paraphrase what I quoted Albert Schweitzer as saying. I really believe that one of the biggest problems in our whole society, Ira Byock, an opponent of physician suicide, recently called it the original sin of medicine, is acting as if we're not mortal or not thinking about the fact that we're mortal. 100% certainty, every one of you and everyone you care about is mortal. And how that fact influences your life or not just at the very end, but even now, is one of the most important issues in what it means to be human. I believe what Albert Schweitzer believed, which is when we think about that for ourselves or a loved one, initially there's this anxiety, we don't want to think about it, but actually as we really reflect on it, then we realize that every day, every hour, every week we have with people we care around us is precious. Even more important, leads to a deeper love for life, leads to a deeper sense of wanting to ensure that we're expressing reverence for the people that we care about in every way that we can. And I think only when we have really deepened, strengthened, and reflected on that can we even come to questions about, and what do we do about this specific topic? So I would urge all of you, as you're leaving here, to be reflecting on the fact that you and everyone that you know and care about is mortal, that every day we have, every week we have is precious, is a chance to actually express that to others, accept that for others, you know, as much as you can with that, and then be thinking, and out of that, if one day I have what Brittany Maynard has, what do I actually think is the best approach that really shows my simultaneous cherishing, gratitude, acceptance, love for my life and other people, and appreciation that we're all mortal and will one day die. And I would rather have you just puzzle with that, think and talk a lot, than suggest any concrete path.
Now, and I guess, particularly for the medical students, just urge you to, even at Harvard, even if 3 books are now up, maintain a sense in practice always of humility. I'm really convinced that part of the drive from physicians for legalizing assisted suicide is the inability to come to terms with the fact that there are some human problems that we can't fix. There are some really serious limits to the craft. The theologian Paul Ramsey once said that the function of medicine is not to relieve the human condition of the human condition. And remember that always, that there are things you are not going to be able to fix about the world in which you practice, and you've got to be able to stand humbly before the patient and with yourself and recognize that, and to sort of emphasize that and to put it in the terms of the context of the mysteries you were talking about. I'll end with a quote from Gabriel Marcel that I'll adapt to medicine, that a patient is not